Hi, I'm Dr. Robert Lillard, Medical Director for the Cumberland Pediatric Foundation, and we are back again for more conversations with Dr. Kathryn Edwards with the Division of Infectious Disease at Vanderbilt Children's Hospital. And we've had these conversations to talk about a myriad of infectious disease topics that affect practices, and we are here today to cover another one of those. We're going to talk about pertussis a little bit, some of the changes and things that are going on, and you're very well versed at this, so we're glad to have you.
Thank you very much. Thank you. I think that there are a lot of things happening with pertussis, and I think sometimes the whole story of pertussis, people don't kind of know it. So I think it's important that we go over a little bit about what we know and why we have the acellular vaccines, and then some of the ways that we need to protect babies, and also a little bit what might be coming down in terms of research. So we know that over the past several years, there has been appreciation that there is more pertussis, that it's probably the least well controlled of our vaccine preventable diseases. And you can say, well, why is that? Well, one possibility is that we have a better way of diagnosing it now. So it used to be that you would have to culture it on the cough plates, and you'd have to call the state and they'd have to make it, and it was always a hard germ to grow. But now we have the ability to do polymerase chain reactions, which are very sensitive, so we have better methods to do it. But we also know that something else has happened, and that is a function of the vaccines that we give. So about 30 years ago, we used wholesale pertussis vaccines that were made of just simply killing the pertussis germ and giving those as an injection. And those vaccines were very effective, but they were very reactive, so that often children would have fevers of 103, 104, have seizures, have red arms, and everyone dreaded the pertussis vaccine. So because of that, people began to say, I don't want to vaccinate my children, and also there were a lot of lawsuits about the fevers and the reactions. So a lot of government money, a lot of my time went into working on new vaccines, and those were more highly purified vaccines called acellular vaccines. And many of those vaccines were actually studied in children from the practices in Nashville. So we would go out to pediatric practices and enroll patients and work on these new vaccines. And the new acellular vaccines were so much less reactive. In fact, when we first began to give them, we would send our nurses out to make home visits on the children. And with 100% certainty, they would predict who got wholesale or acellular. So it was really, really very different. So we all were very excited when the acellular vaccines replaced the wholesale. And we thought we were doing just wonderful. We were just happy as clams, and we thought that we had the problem solved and there was not going to be any problem. Then about 5 to 10 years ago, we began to see outbreaks of pertussis. And the outbreaks were more in adolescents who had been immunized with the acellular vaccines. So what we began to appreciate was that the acellular vaccines were much less reactive, but they didn't produce long-lasting immunity, and the immunity waned. So we began to give extra doses of the vaccine as adolescents, but we still know that the immunity is waning, and most of the children that are getting the pertussis now have been immunized with the acellular vaccine in adolescence. There's some data from California, and there's a couple slides that show that still your greatest risk for getting pertussis, if you're not immunized, unimmunized, if you're under-immunized, but also as you get older, the immunity wanes. And so a lot of cases of pertussis are in people who've been fully immunized, but their immunity has waned.
Right. And I think that slide shows that from 2011, I think it was in California, where most of the younger folks who had acellular pertussis, there was a higher risk than those older ones who had wholesale.
Exactly. Now, I think it's also important, a lot of people who've never given the wholesale vaccine say, well, why don't we just go back to that? And I must say that in our climate, very vaccine critical climate, there would be no tolerance for the reactions associated with whole cells. So I think that we have to remember kind of why we did what we did. And certainly if you ask people what vaccine are they most comfortable with, in general they'll say pertussis because the reaction profile is so good. So the other thing that's happened is that we also have begun to see an appreciation that there are babies that are getting, or that were getting pertussis. And we know that babies that get pertussis are at the greatest risk, so that their risk of getting severe disease, being hospitalized, and even dying of pertussis is greatest before they get their first dose of their DTP at 6 or 12 weeks of age. 6 or 8 weeks of age. So what has happened is that the Academy and the American College of Obstetrics and Gynecology and family practitioners have all decided that what needs to be done to protect those little babies is to immunize their mothers during their pregnancy. So the mothers are immunized with the DTaP vaccine in their pregnancy in the 3rd trimester, and there is a very good immune response so that by the time the babies are delivered, they actually have higher levels of antibody than their mothers have. Babies are really good parasites. They really are good at taking the antibodies. So we found that in general, the approach of using maternal vaccine protects the babies, and now that has been about 90% effective in preventing disease in the babies. We then immunize the babies according to the regular schedule, even though that they've been vaccinated. The levels of antibody in the mothers wane quickly, however, so that every pregnancy needs to be accompanied by a vaccine in the pregnant mother.
And I think we're also trying to immunize any caregivers, be it grandparents,
Right.
babysitters, things like that. And should that ideally be done before delivery?
It should, and I think there's certainly we know that babies don't go, they have to get their pertussis from someone. They're not out, shopping and going to the grocery store, so someone usually will bring pertussis to them. And it could be their parents, their grandparents, it could be their siblings, and so it's really important that we immunize everyone and sort of prevent the baby or cocoon the baby from exposure to pertussis.
New babies bring a lot of visitors, so that's important to think about.
Exactly.
Wonderful. Let's talk a little bit about control in the office, seeing the adolescent with chronic cough. And, again, we talked about these waning immunities. We talked about 9 or 10 being a risk factor, but certainly teens. We see so many allergies in Middle Tennessee. It's easy to think you've got that chronic cough or allergies. You can almost give that diagnosis to anyone. But how should we be looking at these folks who have that cough that lingers on for several weeks? Should we be evaluating them, and should we be treating them?
So several years ago, we did a study in our emergency room on chronic cough, and every person that came in, we enrolled them in a study, and we did their blood to see, whether they had pertussis. And surprisingly, in people who had been coughing for 2 weeks, 20% of them had elevated pertussis titers. So 20% of the people who came in with a chronic cough of over 2 weeks, we've confirmed to have pertussis. So it is something you need to think about. We also know that pertussis does tend to occur in clusters. So, you also can ask, well, are there other kids in school, or are there other adolescents that are having cough as well? So one can do either a PCR or serology. Serologies are often very easy to do. And if they're elevated, then they would confirm indeed that that's what the case is. I think if you are concerned, if the cough is persistent, if there's some element of breathlessness to it, if there's not a past history of allergies or asthma, then what you may want to do is go ahead and send the test, but then go ahead and treat the patient with a macrolide.
Great. All right. Well, thank you so much for watching. Again, this is another of a series of conversations with Kathy. Look on our website for the other episodes, and we hope you watch those too. Thank you.